So pain in orofacial tissues, diseases which can come from the teeth and the supporting tissues, which we know. You can also have mucosal diseases which can cause pain, right? So there are something like the, I'm talking about the desquamatic gingivitis, the Behçet's disease, the ulcerative lesions, right? Most of these can cause extreme pain. Aphthous ulcers, right, can cause severe pain. Diseases of the jaw per se, you can have some claudication of the jaw, you can have osteomyelitis, right? You may not see anything, but the patient can have severe pain. Pain can get triggered by mastication, just opening the mouth and trying to eat something can cause severe pain, right? Neurological diseases on its own right, trigeminal neuralgia. Referred pain, something else from the ear, from the throat, from something from the tongue, anything can get referred over here. Cardiac pain can get referred to the teeth, right? Psychogenic pain. We say psychogenic facial pain or atypical facial pain, right? That is a diagnosis of exclusion. You should have made sure that you have basically ruled out all the other physical causes of pain before you call some pain as psychogenic. Be careful about that. But remember, you can get pain with absolutely no physical signs and symptoms, right? Pain could be the only thing. So neuroanatomy, we know that, but when we come to orofacial pain, when we talked about the peripheral pain, it all goes through the spinal cord and it goes into the first order of neuron, second order. Here in a facial pain, the first order of neuron is the nociceptor. Nociceptor is present all over the surface, skin, inside in your mucosa, in your teeth, the first order of neurons. Nociceptors are there everywhere and they go to the trigeminal nucleus. That's your first order of neuron. And the second order of neuron, there is a decussation. From the trigeminal nucleus, it goes to the contralateral thalamus, right? And from the third order, from that thalamus, so the right-sided one goes to the left. And from the left thalamus, it goes to the post-central gyrus of the left side, right? That is your somatosensory cortex. And you can also get additional signals to the limbic structure and the hypothalamus. This is where we talk about our emotional component of your pain, right? So in a nutshell, so we talk about V1, V2, V3. So we talk about ophthalmic, maxillary, mandibular division. More or less all the pain fibers are going to go through that. It goes through the trigeminal ganglion where it is just goes through, right? And then we go into the trigeminal nuclei till that one, that is your first order of neuron. So we have multiple nucleus, right? The principal nucleus, which is again, we have the motor nucleus. We know trigeminal nerve as a mixed nerve, right? So we have the principal nucleus, nucleus oralis, nucleus interpolaris, and nucleus caudalis, right? So caudalis goes into the more like a, like what you say, medulla type of one, right? So this is where it first order goes, and from here, the second order goes into the contralateral thalamus, right? So from the sensory root, as it goes there, it crosses over and it goes to the contralateral thalamus, and from the thalamus it goes to the somatosensory cortex, where the tongue has got tongue, lip, teeth, gingiva. Most of them have got a fair amount of representation on the sensory cortex. In fact, actually this entire area is probably face. This is the only area which is left for the other parts of the body, right? And the hands and the fingers, they take a very big role. All the other areas of the thing. And of course, this part of the brain goes to the next one, right? The other opposite side one, right? So that is your second order of neuron and the third order of neurons. We saw this earlier itself. Mediators of pain in the peripheral area, we talk about the arachidonic acid pathway, and more often than not, our painkillers always, the so-called NSAIDs act on this, right? So we talk about the metabolites of the arachidonic acid pathway. So we want to stop that pathway. The prostaglandins, again, I'm sorry about my spelling mistake, leukotrienes, etc. So we have their 5-HT, ATP, adenosine, histamine, the bradykinin, interleukins, and the substance P. As I said, substance P, bradykinin are more of central ones, right? But these are mediators. These are inhibitors. These are pain controllers, the enkephalins, dynorphins, and endorphins, which are produced by our own thalamus, right? So they can modulate the pain perception, right? That's an important thing. But whenever we talk about pain, evaluation, where is it? Sight. How do you say about the character? People will tell you very clearly it is a stabbing type of pain, it's a burning type of pain, it is throbbing in nature, it's aching, it's so dull. Severity, it's so severe that the severity, the significance of that severity obviously varies from patient to patient. Duration, started yesterday, acute pain. Well, it's been like that for the last 2 years. It's a pretty chronic pain, right? Periodicity, you have times where you have no pain. Somebody says it's a continuous type of pain. Somebody says it comes in the morning, it comes once a month, it comes once in a blue moon, right? But when it comes, it can be very severe. Periodicity. All that needs to be, because everything will define what type of pain it is, right? Is it radiating? Is it just a local pain where if the patient can just put one finger or one thing and then say exactly where it is, right? Or is it just starting and then it goes on to the entire side? It's whether it is a radiating pain. What are the provoking factors which brings in the pain? What are the relieving factors? We call that as an aggravating factors. You can have a provoking, which is initiating, and something can aggravate it, right? So I just took a coffee, doctor. The pain became so severe, it's an aggravating factor. Relieving factors, certain things relieves me. If I just do this, the pain gets relieved and I'm okay with that. What are all the associated factors, right? So this is about pain evaluation. So if you first talk about it, what are all the orofacial regions, like which are all the teeth related areas, teeth and supporting. I'm really sorry about a lot of spelling mistakes. Pulpitis, very common, isn't it? Right? So we talk about a caries, a dental caries causing a tooth pain. Pulpitis can be a very severe facial pain.